afternoon, everybody. So, this month's SR update will be done by Dr. Anna, who is a senior registrar at Lady Hospital, who will be presenting some interesting cases in dermatology. Over to you, Anna.
Thank you very much, madam. First of all, I would like to thank Sri Lanka College of Dermatologists to giving me this opportunity to present interesting pediatric dermatology cases which I have encountered during my training period. So I will start with the case 1. This neonate presented with this lesion. So you can appreciate there is erythematous lesion involved in the right side of the forehead and the right upper eyelid. It was not present at birth and it was progressively enlarging in size. So clinical diagnosis is obvious. This is infantile hemangioma, which is plaque type. Usually it is associated with other syndromes. Facer syndrome. Facer syndrome is an acronym which denotes posterior fossa brain malformation, plaque type hemangioma, usually in the face and the scalp, and arterial abnormalities, cardiac abnormalities, eye defects, and sternal defects. So we excluded Facer syndrome with the relevant investigation, and then we started definitive treatment for the hemangioma. We started the oral propranolol, 1 milligram per kg per day dose. Actually, we usually start propranolol is started as an inward patient with the monitoring of vital sign. Dose increase up to 2 milligram per kg per day. It is the therapeutic dose within a few weeks time, and treatment continued for 9 months duration. This is the picture after 2 months of treatment. You can appreciate it. Initially, child can't open the eye. So now, after 2 months of therapy, she can open the eye. If we don't treat this lesion initially, there is a risk of amblyopia. So I will discuss latest management of infantile hemangioma. Infantile hemangioma is a benign vascular tumor with unique characteristic. It is usually not present at birth, appear little late, usually during first weeks or months. It has rapid proliferative phase followed by gradual involution. And it has unique immunohistochemical markers. Do we need to treat all infantile hemangioma? No. If infantile hemangioma is superficial, located in the covered area, which can be covered with the clothing, and not causing any cosmetic disfigurement, we don't need to treat the hemangioma. But there are instances which we have to treat early as possible. These are the instances we have to treat: life-threatening complication, functional impairment, associated structural anomalies, increased risk of ulceration, and potential for the disfigurement. We'll see one by one. So, in life-threatening complication, laryngeal hemangioma is the one of the fatal complication. It typically involves the subglottis area and causing upper airway obstruction. Usually patient present with stridor, biphasic stridor with the proliferation of hemangioma. One interesting thing is most of the children have cutaneous hemangioma in the lower face or anterior neck with association of laryngeal hemangioma. So that is a good clinical clue to exclude laryngeal hemangioma. This is the photo with the infantile hemangioma in the beard area with associated with laryngeal hemangioma. Other fatal complication is with multifocal hepatic hemangioma. Hepatic hemangioma, there can be focal, multifocal and diffuse. Usually focal hemangioma doesn't cause any complication, but multifocal hemangioma and the diffuse hepatic hemangioma, when it is associated with macrovascular shunt, they can cause high output cardiac failure. Abdominal compartment syndrome leading to compromised vasculation, and the renal failure due to inferior vena cava obstruction. And also they secrete enzyme which break down the thyroid hormone and causing consumptive form of hypothyroidism. This is a child. Recently we got the referral from the ICU with multiple diffuse hemangioma in the liver, and this child had more than 5 cutaneous hemangioma also. So children with multiple cutaneous hemangioma, more than 5 known to be associated with multifocal and diffuse liver hemangioma. So we have to screen with the ultrasonography as early as possible, and we have to treat early. Another indication for the treatment is functional impairment. Periocular involvement, especially it can cause mechanical ptosis and squint leading to amblyopia if we don't treat early. And the involving lip or oral cavity cause feeding difficulties. And some infantile hemangioma, when it occurs in a particular sites, more vulnerable to cause ulceration, especially in the scalp, face and perineal area and intertriginous areas. So we have to pay attention when this is associated with these sites. We have to start treatment early. Usually ulceration occur in the rapid proliferative phase. And when it is associated with structural anomalies, we have to screen for the other association with the relevant investigation. Faces syndrome I have already discussed. This is lumbar syndrome and the pelvis syndrome with lower body hemangiomas. This is the few patients we encountered with lumbar syndrome. And potential for disfigurement is another indication to start treatment. Because of the scarring as well as distortion of the anatomical landmarks causing disfigurement. So these are the vulnerable area to cause disfigurement. So when it is present, we have to treat early. So oral propranolol is the drug of choice for infantile hemangioma requiring systemic therapy. The one drawback is with propranolol, it is low solubility. This is the only oral preparation available, which is very expensive, which is not available in our country. What we do is we make the powder propranolol, make the propranolol powder and mix with glucose base and divide it into doses and give it with the breast milk. So mechanism of action of propranolol on infantile hemangioma varies: immediate vasoconstriction, decreased expression of pro-angiogenic factors, and induction of endothelial cell apoptosis. So, how we prepare for the patient for propranolol therapy? We have to assess the cardiac status with the 2D echo and the ECG, and we have to exclude underlying other abnormalities. Treatment dose, starting dose is 0.5 milligrams per kg per day, and usually we start the treatment as an inward patient. If there is no complication, we can discharge patient following day. Therapeutic dose is the 2 to 3 milligrams per kg per day. Regarding side effects, no much side effect we have encountered, but there is a risk of hypoglycemia because of the inhibition of the gluconeogenesis and glycogenolysis there is a risk of hypoglycemia in infants, so we have to give it after meal, and there are other few side effects also there. Another question is, can propranolol therapy affect the brain development? Because propranolol is a highly lipophilic drug. It can cross the blood-brain barrier. In adult studies, there is known to impair the short and long-term memory as well as the psychomotor function. But large prospective randomized trial and 4 other studies have shown there is no delay in neurodevelopment and psychomotor function with propranolol therapy in children, so it is safe for the children. The other option are topical timolol and oral steroid and intralesional steroid, and the surgical removal and the PDL laser, basically other residual damage. Then I will move to the case 2. A neonate transferred from the local hospital with large tumor involving left upper limb. There was whole left upper limb was swollen and purplish black in color. And ecchymotic patches were there, other areas also, and the platelet count was 30,000. So with the clinical picture, we diagnosed Kasabach-Merritt phenomena. Kasabach-Merritt syndrome is a consumptive coagulopathy with underlying locally aggressive vascular tumor which causes platelet trapping, platelet activation, and concomitant fibrinolysis. So acute management involves stabilization of the patient, and we have to start on steroid. Our preference is IV dexamethasone, 1 milligram per kg per day dose in 4 divided doses. At this point, platelet transfusion is contraindicated even though platelet is low, because it can worsen the consumptive coagulopathy, and the blood product contain pre-angiogenic factors which worsen the disseminated intravascular coagulation. Then we have to treat for the underlying vascular tumor. Our child had caposiform hemangioendothelioma. Actually, that was clinical diagnosis. It is a rare locally aggressive vascular tumor. So there are various options for the tumor targeting therapy. The most popular one is IV vincristine, but the drawbacks of IV vincristine is we have to transfer the patient to Maharagama, as well as it caused by symptomatic bicytopenia. So as our previous experience, we started on methotrexate. With the methotrexate, our patient improved dramatically, and after few months, the tumor has came to a very small level, and child is improved and the platelet counts are normal. Another option is the sirolimus, which is popular among developed countries. We recently got a child who was treated at Australia with a sirolimus but poor response. Child came to us with a Kasabach-Merritt phenomena with a drop in platelet. We stabilized the child with IV dexamethasone. But we couldn't give methotrexate as platelet count is very low, so we transferred the child to the Maharagama for IV vincristine. I will move to the case 3. This is a 10-year-old boy presented to us with a fever and skin rash for 2 weeks duration. There was no history of recent infection or drug history. On dermatological examination, there was erythematous papules, plaques, and few necrotic lesions. Child had low-grade fever. Mucosa was not involved, so fever was our diagnosis, and we started usual treatment, oral antibiotics, short course of steroid and topical steroid. This is the skin biopsy with epidermal necrosis and intraepidermal red blood cells and interface dermatitis. So despite of treatment, child progressed with generalized erythema, skin tenderness, and worsening of the ulceration, and there was perioral crusting, and there was flexural herpetiform ulcers. So with that clinical, there was multiple vasculitic lesions in the both palms and sole. So with that we made the diagnosis of ulcerar nectative fever, Mucha-Habermas disease, which is complicated with Staphylococcus aureus skin syndrome and herpes simplex infection. So we transferred the patient. Mucha-Habermas disease is a severe variant of fever. It is characterized by destructive ulceronecrotic lesion accompanied by high fever with systemic manifestation like arthritis, pulmonary involvement, and central nervous system symptoms. So fulminant nature of the disease and the extensive skin involvement predisposed to nosocomial infection and sepsis are the challenges in managing Mucha-Habermas disease. So we transferred patient to the intensive care unit and we started on antibiotics and antiviral drugs, IV Sovirax, and we couldn't continue oral steroid as with the sepsis, and we started on acitretin. But with acitretin, there was no much improvement. So we extensively searched, we reviewed the literature, and there were a good place for methotrexate. So we started methotrexate weekly dose. After 2 weeks, I completely recovered with residual post-inflammatory pigmentation. So then moving to the case 4, 10-year-old boy transferred from Batticlo with high fever spikes, skin rash, oral ulcers, conjunctival hemorrhage, and parotid swelling. This is the child. There was erythema multiforme lesion, and there was subconjunctival erythema, and there is suggestion of DLE-like lesion. So, and there was high spiking fever here, this initial. So we made the clinical diagnosis, Dravet syndrome. It's a rare disease consisting of erythema multiforme lesion associated with lupus erythematosus. And the immunological features, positive ANA with speckle pattern and positive anti-lion Rho antibodies with reactive rheumatoid factor. But we had to revise our diagnosis as this ANA and anti-ROLA and the rheumatoid factor all were negative. So we observed this child, and then we noted this classic heliotrope rash in the upper eyelid. So we made the diagnosis of juvenile dermatomyositis, and extractable nuclear antibody panel confirmed with the positive anti-Jo antibodies. And we started on IV steroid, later methotrexate. While on steroid, child developed dysphonia. But we thought whether it is worsening of the disease due to weakness of the laryngeal muscle and unusual presentation, whether it is associated with malignancy. So we rushed to laryngoscopy, and there they noted whitish nodule in the vocal cords. They called as bamboo nodes, and these are immune complex deposition which associated with autoimmune connective tissue disorders. So it was improved with continuing therapy, and the phonation also returned to normal. And child was improved dramatically. So this is my last case. 11-year-old boy presented with fever for 2 weeks and cervical lymphadenitis and erythema nodosum-like lesion in both chin. This is the picture. And child was extensively investigated at medical ward, and ESR was very high with a neutrophil leukocytosis, and MAR2 was negative, chest X-ray normal. But lymph node biopsies showing granulomatous infiltration with a histiocyte admixed with neutrophils. And there were necrotic materials also. And Nielsen test pass and the gram stain was negative. So they were atypical mycobacterial infection. So they were about to start treatment for atypical mycobacterial infection. But our previous experience and melioidosis can have diverse clinical presentation. We suggested melioidosis also as a differential diagnosis. Then later melioidosis antibodies were strongly positive, more than 10,000. So they started definitive treatment and child improved. So these are my references, and I would like to thank my teachers, Professor Jamini Seniviratna and Dr. Shriyani Samaravira and Dr. Chandani Vikramatna for continuing support of my career.